Lymphoma Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the Lymphoma Hub podcast. Today we'll be hearing from Catherine Diefenbach from Perlmutter Cancer&nbsp in New York, US.
Hello, I'm Dr. Catherine Diefenbach from the Perlmutter Cancer Center of NYU Langone Health, and I'm speaking to you today about some of the abstracts that were presented at virtual ASCO in the lymphoma space that are very exciting in immunology and immunotherapies. So I will be speaking to you today about 3 studies involving the antibody-drug conjugate polatuzumab vedotin, as well as the bispecific antibodies mosunetuzumab, glofitamab, and epcoritamab. And then I'll also be speaking to you about follow-up data that is more long-term data from the L-MIND trial looking at a novel CD19 directed antibody called tafasitamab. So this is all, it's always wonderful to have new and exciting data to discuss in the lymphoma space. And hopefully we will soon be able to see this data in person again. But here are some of the highlights of virtual ASCO. So there were 3 studies that looked at the antibody-drug conjugate to CD79 polatuzumab vedotin, which is a CD79 targeted antibody-drug conjugate that is a conjugate to calicheamycin, a taxane-like compound. And in the first study, of which I was the lead author, polatuzumab was combined with rituximab and lenalidomide for patients with relapsed and refractory diffuse large B-cell lymphoma. And patients in this study received induction therapy with 28-day cycles of polatuzumab at 1.8 milligrams per kilogram, standard dose rituxan, and len at escalating doses. Patients who had a response at the end of induction then got 6 months of consolidation with rituxan and lenalidomide. At the primary analysis, 57 patients were enrolled, and the median age was 71. This was a heavily pretreated patient population, with 11% who had prior bone marrow transplant and 5% who had prior CAR-T and 49% who had primary refractory disease. 65% were refractory to their last therapy. The therapy was quite safe, although there were grade 3 to 4 adverse events were experienced by 75% of patients. The most common were neutropenia and thrombocytopenia, which were expected. There was 25% dose reduction of lenalidomide and 63% dose interruption. There was 1 grade 5 treatment-related AE, which is neutropenic sepsis. There were 49 patients who were treated at the recommended phase 2 dose of Pola 1.8 and Len 20. And the best overall response by investigator was 74%, with 35% of patients achieving a CR. Of those, 82% remained in remission at the cutoff date and with a duration of response of 8.1 months. At a median follow-up of 9.7 months, the median progression-free survival was 6.3 months with an overall survival of 10.9 months. In another study, polatuzumab was combined with mosunetuzumab for patients with relapsed and refractory non-Hodgkin lymphoma. And I have to disclose that I was also an investigator on this abstract. Mosunetuzumab is a full-length humanized IgG bispecific antibody that targets CD20 and CD3. And it has shown promising efficacy as a single agent. Here it's combined with the anti-CD79B antibody-drug conjugate polatuzumab vedotin. And this study included patients with relapsed and refractory follicular lymphoma or aggressive non-Hodgkin lymphoma, including transformed follicular lymphoma and grade 3B follicular lymphoma. As of the cutoff point, 22 patients had received Pola, 32% of patients had prior CAR-T, and 86% of patients had disease refractory to last prior therapy. Median follow-up was 9.6 months. The combination was well tolerated with neutropenia, fatigue, and nausea, the most common adverse events. CRS was only observed in 2 patients, both grade 1 by criteria. There was 1 grade 3 DLT, which is new onset AFib, and the maximum tolerated dose was not exceeded. 2 grade 5 AEs, both sudden cardiac death and respiratory failure, were observed, and neither was deemed treatment-related. The overall response rate for all patients was 68%, with a 63% overall response rate for the aggressive patients and a 57% overall response for the post-CAR patients. The indolent lymphoma patients had a similarly high response rate, and the complete response rate was was 47% for the aggressive patients, 28% for the post-CAR patients. And this is very exciting data, particularly for patients who are post-CAR, to have a 28% complete response rate and a 47% complete response rate for patients with aggressive non-Hodgkin lymphoma. The next abstract that I'm going to share with you is an abstract that examined polatuzumab with obinutuzumab and venetoclax in patients with relapsed and refractory follicular lymphoma. So obinutuzumab is a fucosylated anti-CD20 antibody combined with polatuzumab, as well as the BCL2 inhibitor venetoclax. And these patients received induction therapy every 21 days for 6 cycles, of which the recommended phase 2 dose was polatuzumab 1.8 milligrams per kilogram, venetoclax 800 milligrams, and standard dose of obinutuzumab. At the primary analysis, 74 patients were enrolled. 55% had a high-risk FLIPI, and 51% were refractory to their last prior therapy. 55% were refractory to both anti-CD20 and an alkylating agent. 73% of patients had adverse events, most commonly neutropenia and thrombocytopenia and infection. 38% had dose reductions. 1 fatal AE was reported, that was pneumonia. 49 patients were treated at the RP2D and were evaluable for efficacy. PET-CR rate at end of induction was 57%. And with a median follow-up of 14.4 months, the 12-month progression-free survival was 73%, with a median PFS that was not reached. The CR rate was 57%. Additional follow-up is needed to assess the PFS benefit during maintenance treatment and beyond. So this study is ongoing. There were 2 other novel bispecific antibodies that were presented at this meeting. One of them is glofitamab, which is a novel 2-to-1 bispecific, which basically allows bivalent binding to CD20 and monovalent binding to CD3. And this is, the hypothesis is that this allows a higher activation of T cells with respect to their target cell. Glofitamab was given using step-up dosing on day 1 and 8 of cycle 1, and then at the target dose from cycle 2, day 1, for up to 12 cycles every 21 days. So 52 patients received glofitamab. 28 patients had aggressive lymphoma, and 24 patients had indolent lymphoma. Patients had again, these were heavily pretreated patients with a median of 3 and 1 to 12 prior lines of therapy. 77% were refractory to their most recent prior therapy. With an updated efficacy analysis that was the most recent updated analysis, the best overall response for aggressive lymphoma was 64%, with a CR rate of 57%, and a trend of increased overall response with the target dose, with a CMR of 71% at the highest target dose. In mantle cell lymphoma, small numbers of patients were evaluated, but 80% of patients had a CR. And in the aggressive lymphoma patients, 13 of 16 CMRs are ongoing, with 8 lasting more than 3 months. For the indolent patients, the overall response rate was 79%, with a 70% CR rate, and 14 out of 17 CRs ongoing, with 10 CRs lasting more than 3 months. The most common adverse events in 52 patients were CRS in 63%, neutropenia in 38%, and pyrexia in 32%. CRS was mostly confined to cycle 1, and it appeared to be dose-related. Grade 1 and 2 CRS were reported in 18 and 12 patients respectively. 3 patients had grade 3 and none had grade 4. So this data suggests that glofitamab monotherapy showed a high preliminary response rate in relapsed and refractory non-Hodgkin lymphoma, especially in aggressive non-Hodgkin lymphoma. CRS appeared to be manageable, was primarily confined to the first cycle of treatment, and was generally low grade. 2 other abstracts of note: epcoritamab, which is a subcutaneous CD20/CD3 bispecific, was evaluated also in relapsed refractory B-cell non-Hodgkin lymphoma. Patient population was similar to the populations of the studies that I've described. And the overall response rate in DLBCL for epcoritamab was 68%, with a CR rate of 45%. At the higher dose, the overall response rate was 91%, with a CR rate of 55%. For follicular lymphoma, the overall response rate was 80%, with a CR rate of 60%. And for mantle cell lymphoma, the overall response rate was 50% with a CR rate of 25%. The median PFS for patients with DLBCL was 9.1 months. And for patients who received the higher dose, the median PFS for DLBCL was not reached. So this is another exciting drug that we have for patients with relapsed and refractory indolent and aggressive lymphoma. And finally, there's the long-term analysis from the L-MIND phase 2 study of tafasitamab combined with lenalidomide in patients with relapsed and refractory diffuse large B-cell was presented. This basically was a study where patients were randomized to an FC modified humanized anti-CD19 monoclonal antibody plus lenalidomide in patients with diffuse large B-cell lymphoma. For patients who received TAFA plus len, there were 81 patients at data cutoff. The overall response rate was 57%, including complete response in 40 patients. The median PFS was 11.6 months, with a median follow-up of 33.9 months, and the median overall survival was 33.5 months, with a median follow-up of 42.7 months. There were no unexpected toxicities or new safety signals. So I think this long-term follow-up data shows that that treatment with tafa-len followed by tafasitamab monotherapy provided durable responses in patients with relapsed refractory diffuse large B-cell lymphoma who were not eligible for stem cell transplant, with a manageable safety profile that did not show any new or concerning safety signals. And the long-term data does show that the patients who respond appear to achieve prolonged remission and show a survival benefit in this patient population, particularly when they're early in treatment at first or second relapse. Thank you for your attention.
Thank you for listening to the Lymphoma Hub podcast. We would also like to thank our supporters, Bristol Myers Squibb, Genentech, Incyte, Roche, and Novartis.
Lymphoma Hub podcasts, brought to you by Scientific Education Support.